Stephen Fowler. So Stephen is Professor of Respiratory Medicine at University of Manchester, an honorary consultant respiratory physician at Manchester University NHS Foundation Trust. So Stephen's clinical and research interests lie in diagnostics, classification and management of airways disease, and particularly in asthma. So he's been investigating novel non-invasive biomarkers for phenotyping inflammatory and infectious lung disease through detection and analysis of VOCs and exhaled breath. So Stephen, thanks so much for joining us. I'm really looking forward to your talk. And again, a quick reminder, if anyone has questions through the talk, just post them to the Q&A at the bottom. Thanks, Steve. Over to you.
Hello. I'm going to talk about clinical applications of breath analysis and certain aspects of study design. I'm going to talk about this particularly in relation to my main disease of interest, which is asthma. I'm going to briefly start by reviewing the evidence on breath volatile organic compounds for the diagnosis of asthma, talking about two recent systematic reviews. I'm going to talk a bit about the study quality assessment that's required when performing those systematic reviews, because that, I think, needs to inform our future study design. I'm then going to give an example of a biomarker discovery study that we're running in Manchester called Radica, and explain why I think it's a good platform for discovering breath biomarkers. And then I'm going to go on and give examples of different aspects of breath biomarkers that may be related to other applications than diagnosis, in particular related to disease phenotyping, drug monitoring. So I'd like to start just by bringing up this systematic review, which was published in the European Respiratory Journal last year by Adnan Azim and colleagues from Southampton. They went on and tried to perform a systematic review of the breath volatile literature. They predefined what they thought their ideal studies would be, and I think this is informative for us. They felt that the ideal study for their review would first of all prospectively recruit patients with asthma, diagnosed according to internationally recognised guidelines. Now, I'll come back to this because that isn't as simple as you might think. And secondly, studies that measured exhaled volatiles consistent with recently defined recommendations, including well-defined cutoff values against adequate reference standards. Now, in this regard, I think they were hoping and thinking that they would find reports of volatiles in relation to normal values, perhaps some degree of quantification, in much the same way that we now have available data on exhaled nitric oxide. They, I think, quickly realised that they wouldn't be able to fulfil such stringent entry criteria, and they later confessed that they needed to use much more liberal inclusion criteria. This year, we published a further systematic review in cooperation with colleagues in Norwich, Adam Peel being the first author. We decided that we would also look at the volatiles that were actually reported in the studies to see if there's some degree of reproducibility across studies. We felt that if this were the case, especially given studies use different methods for patient recruitment, for sampling, and for data and sample analysis, then this will provide a degree of validation that some of these markers may indeed be important. We did find certain biomarkers repeatedly reported across multiple studies, which of course appears promising. On the other hand, in several studies, there was no mention made of whether these volatiles were present in raised or lowered concentrations in asthma. It was just simply reported that they were found. So we don't really know if these represent biomarkers of asthma per se, or just commonly found volatiles in the breath. So why aren't we getting closer to the patient yet? Breath volatile analysis has been around now for much longer than exhaled nitric oxide. Of course, it's complicated because there are so many more volatiles that we're looking at, but you would hope that soon, either to date or in the near future, we will get closer to clinical application. So I'm going to talk a little bit about where is the clinical need and what is the most important gaps in breath analysis. Is this in diagnosis, in phenotyping, or in predicting treatment response? We published a review a few years ago in the Journal of Allergy and Clinical Immunology that explored this. And I think it is worth thinking about when you're designing your study, what is the area that we want a biomarker for? So to talk first about diagnosis, which really is the most obvious area to look at, I suppose. There are many diagnostic studies in asthma, or COPD for that matter, looking at breath volatiles, and just about all of them suffer from the same sort of limitations, including my own study, which I've put the reference for down at the bottom, just to make it clear I'm not limiting my criticism to others' work, but to ours as well. So the first issue with asthma, and especially with COPD, is what is the gold standard? Is the gold standard diagnosis in some way likely to be related to a change in airway metabolism that then might be reflected in airway biomarkers? So COPD, for example, is defined entirely on the basis of airway caliber. So you measure lung function, do a breathing test where somebody blows out hard and fast, and if the flow coming out of the airways is reduced, then you can diagnose COPD. Now, as you might imagine, this could be due to many, many different reasons. It's not related directly to an underlying specific pathophysiology. And so if we go looking for biomarkers in relation to this so-called gold standard, we may only, in fact, be finding biomarkers of airway obstruction rather than what we presume to be the underlying disease. The other problems with breath studies, in particular in asthma, that have been published so far, is that often they recruit patients with established disease. So these are patients, severe asthma is a good example. They've often had asthma for an average 20 or 30 years. They're often in their 50s on average, and they've been treated with drugs. They've had recurrent infections, recurrent flare-ups over all that time. So if you take that as the case group, and then you have a control group of healthy people, there's clearly going to be a big difference between that established asthma disease and somebody who's coming who needs a diagnostic done, which would be somebody with a new presentation of breathlessness and wheeze. The control groups are often imbalanced. This is sometimes difficult, especially in diseases of aging, such as COPD. It's difficult to get a control group that's a similar age. In asthma, there's a gender split in that more commonly affects females and males, so that needs to be controlled as well. And of course, there are certain things that you can't control because they're unique to the disease, and in particular, that would be treatments and the airflow obstruction that I've mentioned earlier. Coming on to treatment, this is really important in asthma. The key treatment in asthma is steroids, inhaled usually, and sometimes oral steroids. These are treatments that modify the inflammation that's going on in the lungs, and so will change the signal in the breath. I'll come back to exhaled nitric oxide here. This has been under research as a potential biomarker for asthma now for probably 30 years. Initial studies showed some promise, but then some later studies showed a real disconnect between airway inflammation measured in other ways, such as sputum eosinophils, and nitric oxide, and this caused some consternation. This study by Karatinov demonstrated the reason for this disconnect. In people who had asthma and are treated, so in the scatter plot, the people on the right here, there was no real difference in average exhaled nitric oxide between those and healthy people. However, if you took people who were untreated, who were not on inhaled steroids, then there clearly was a big difference. So if you'd gone looking for the biomarker exhaled nitric oxide in a discovery study in people who had definite asthma but were on treatment, then you may well have missed that signal, and you may have missed the opportunity to identify that potential biomarker. I'd like to briefly talk about our ongoing study, which is called Radica, which is an asthma diagnostic study that's funded by the NIHR Manchester Biomedical Research Centre. This study was set up really as a platform to identify and recruit patients at the opposite end of the asthma journey. So we're trying to recruit people who a GP thinks might have asthma. And what we've offered to those GPs is we'll take them off their hands and we'll do all the diagnostics. We'll also recruit them to our research study, but we'll do the diagnostics and we'll give them the initial treatment over an 8-week period to see how they're responding. This has been very hard or difficult to set up, but it's certainly been worthwhile. A GP now in our local area around Wythenshawe, if they start to see a patient with suspected asthma and they start to type in to their patient records, electronic patient records, suspected asthma, then they'll get a pop-up that says, please consider referring to our centre. And before COVID, we had to briefly stop recruitment anyway because we were overwhelmed with referrals. So this is the exact target population that you might need a diagnostic test in. They've not had any oral or inhaled steroids before testing. The GP may have given them a bronchodilator, so salbutamol to take as and when required, but this really hasn't been the case in many patients anyway. We've so far recruited 117 patients over the course of about 12 months. Again, we had to stop during COVID, and we just restarted recruitment this week. And as it's turned out, amongst those 117 patients that we've recruited so far, about 60% have turned out to have asthma, and about 40% have not had asthma. So we've got quite a nice case control split there. The gold standard I've come back to from before. For asthma, you have to demonstrate that there's variable airflow obstruction, and this can often take 3 or 4 different tests over 2 or 3 visits. So we're doing all those tests. We're giving them monitored treatment for 8 weeks, and we're looking at their response to treatment. Then all that data is reviewed by a panel made up of myself along with 2 other asthma consultants, and we decide in each case whether this person has asthma or not. And I think that's generally acknowledged to be as close to a gold standard diagnosis as possible. The other thing to consider is the setting. This, I think, is ideal for a discovery study, not ideal for a validation study, because a validation study you need to go more into the real world and see if your biomarkers perform outside this controlled environment. But we're collecting samples in a single lab with a single group of researchers using one lot of sampling and apparatus, and using the same analytical method for the breath samples as well. Next, I'd like to just propose that if we're going to be looking for some breath markers, we need to think about the hypothesis. Is the change in airway metabolism or airway dynamics likely to be associated with a predictable change in breath volatiles? I mentioned in COPD that this may not be the case when you're just talking about airway caliber. This figure here just shows lots of potential sources of volatiles. And if we're looking in the breath, we need to think where these are coming from. So all of these actually are relevant to any disease really, but we could look at them in regard to asthma. So over on the top right there, we've got a representation of smooth muscle, which becomes remodeled in asthma, increased in bulk and increased in turnover. So that might generate a change in volatiles. The microbiome is changed in asthma, especially by treatment, but probably even before they've had treatment. Mucus is a big feature of asthma. It's usually eosinophilic in nature, but again could be infected or neutrophilic. The inflammatory cells in the airway and in the epithelium and in the subepithelium are altered in asthma and may give rise to a change in volatiles. There's epithelial damage in asthma, especially in COPD. And finally, of course, we need to consider that volatiles in the airway will be in equilibrium with the blood. And so the airway gives you access to sampling from systemic diseases or systemic characteristics such as changes in weight, changes in diet, systemic inflammation, and of course, drugs. So this brings me on to the next potential application, which is treatment monitoring in asthma. We studied this in UBioPrep, which was a large multi-centre EU-funded severe asthma study in which breath was collected across multiple centres. We were rather fortunate in the study design in that some centres started up sooner than others with their breath analysis. So at baseline, we aimed to collect breath samples on everyone who entered the study, but we did not get that. We only got those samples on about 48 patients. We then followed up the patients 1 to 2 years later. Some of those patients came back and had another set of samples, which we've called the replication sample. But some patients who had not been sampled at baseline because their centre hadn't started sampling yet, then had samples done 12 to 24 months later. And so we had, at least to a degree, an external validation set here. This table just shows the demographics, and really there was not much difference between the 3 groups. We measured salbutamol and we measured prednisone. This leads me to an aside just about adherence and drug monitoring. If we are doing studies where we want to look for biomarkers of drugs, it's not enough, especially in asthma, just to ask the patient what drugs they're taking or what drugs they've taken recently, because unfortunately in asthma, we know that only about 1 in 3 people actually take the drugs that they're prescribed by the doctors regularly. So in this study, we actually measured prednisolone and its metabolites in the urine. And so the gold standard here was the detection or non-detection of these drugs in the urine versus the breath profile. We performed multivariate analysis. The volatiles that were most commonly identified in the discriminant analysis shown here on the left. The central ROC curve is the baseline model, and the right-hand ROC curve is the validation, the external validation set, and you can see that both performed reasonably well. I'll just draw your attention to these 2 volatiles, glycolic acid and octanol, which I'll show on the next slide too. So we then went on to perform linear regression because we had quantity of prednisolone in the urine, and we wanted to see whether a model could predict the concentration in the urine in a linear way. We were indeed able to generate a model and of interest. The volatiles that contributed most to it were not exactly the same, but 2 of the 4 were the same. Octanol is an aldehyde and therefore likely to be related to airways inflammation, and therefore likely to be represented in this model because of the effect of prednisolone on inflammation. The other marker that came up again was glycolic acid, which is interesting because structurally it looks like possibly it's related to the N-terminal of prednisone itself. So this may actually be a breakdown product of prednisone. Of course, this needs validating in subsequent data set. The next thing to consider is what performance is needed from the test. I'll be fairly brief here, but just to say that aiming for an area under the curve or an accuracy of 100% for any test is, first of all, possibly not realistic, and secondly, not even necessary. When you're thinking about the disease under study or the application under study, we need to consider whether what we really want out of the test is a high sensitivity or a high specificity. And indeed, your biomarker may work for one and not the other. And if so, that may not be a problem. So blood eosinophils, for example, we use to identify whether someone has airway eosinophilia in asthma. And blood eosinophils at a high level are very, very good at picking out people with airway eosinophilia. However, if they're low, they don't really help. It's about 50-50 as to whether that person has eosinophilia or not. A combined group from Belgium and the Netherlands have published a combination of breath volatiles along with blood eosinophils and shown that they are complementary and produced much better accuracy when used together than when used separately, as shown in this figure over here at the bottom right. Finally, we need to consider whether we practically can design a study that has a reasonable chance of getting reliable proof of concept, especially at this early stage. We need to think a bit about recruitment. I won't talk more about this apart from saying that I've been involved in studies where we've not been able to recruit patients with the disease under study, often because they've been too sick to provide samples at the time. So this is something that certainly needs to be considered. The other thing I want to mention is confounders, which I think we'll hear a lot about over the next 2 days. I want to mention one in particular, which is circadian rhythm, because that's of particular relevance to asthma. Circadian rhythm is obviously the natural rhythm in various physiological and inflammatory cells in the body. In asthma, it's exaggerated. So people with asthma have much worse lung function and they have more airway inflammation at 4 a.m. than 4 p.m. So we did a study where we kept people in a research room for 24 hours and they just went through the normal cycle of sleep and wake and eating. And we sampled breath 4 times over that period of time. Half of these patients were people with asthma and half were healthy controls. We noted significant circadian variation in these breath volatiles shown on the left amongst all patients. Interestingly, you'll see the very commonly reported compound isoprene on the left. I think this just emphasizes that it's absolutely vital that time is controlled if we are doing breath analysis studies. The one on the right, chlorobenzene, made us think that it was likely to be potentially an environmental contaminant. However, we did collect environmental samples at the same time and did not notice any circadian rhythm in that or in any other compounds for that matter. The subject numbers, when we broke them down into healthy and asthma, are obviously much fewer, about 10 in each group, but we did see disordered circadian rhythm in asthma. There's 2 examples there, camphene and xylene. So finally, I think at this stage where we're still discovering biomarkers, good experimental design is absolutely essential. We need to think what the clinical and biological hypothesis is, otherwise we might end up in a situation where we find a result, and often we will when we're doing a multivariate analysis of large data sets, and we won't quite know how to explain it. It's much better to think the hypothesis first and then go about seeking to address it. We need to think whether breath is likely to provide an answer. Is the disease on the study likely to relate to changes in breath volatiles? We need to think what we need from the test. Do we need high sensitivity, specificity? And finally, can we actually do the study? If not, if we can't answer all of these questions, then we shouldn't probably be doing it, at least not on our own. If we can get all this right, we'll hopefully soon be getting towards good external validation studies and then onto clinical effectiveness studies. So I'll finally be able to use it in my clinic. I'd like to thank you for listening. This is my acknowledgement slides of my mentors, my colleagues, my teammates, and my funders. I'd be very happy to take questions.
Brilliant. Thanks so much for that, Steve. So as I said, there's a few questions that come in through the session. So the first one from Karsten is, how certain are you about the identification of the actual compound? So some of the things that you mentioned earlier in the presentation, Karsten said, in LCMS, this is still a wide field of research. And I think we've seen similar types of challenges where you might get a tentative idea on something, but how do you know it is what you think it is?
Yeah, I think that's obviously a problem, especially when you're doing, we reported those systematic reviews in my presentation. And when you come to look at other people's work and their own work, people report different levels of certainty, and some people don't acknowledge that as a problem at all. There's the Metabolomics Standards Initiative, which advises people to report what level of certainty they've got and whether, for example, they've injected standards to really prove that it's that compound as well as they can do. So we just encourage people to do that, to go as far as they can go, and report the level of confidence in the papers when they're published, so that we all know how confident we are. I mean, that table that I put up there, there'll be a different level of confidence for different compounds in the table, and some of them we really won't know.
Yeah, thanks for that. Next question is from Alexis. So some of the listed VOCs that were detected in asthma COPD share similar properties. So how do we know these are VOCs that are indeed related to asthma pathophysiology and not just a byproduct of other metabolic reactions of most tissues?
Yeah, so I mean that's kind of exemplifies the point. And one of my slides was about potential sources of VOCs, and if you take a breath sample, it can be coming from anywhere. I mean, first of all, outside, it could be coming from outside the body and going in and coming back out again. But even within the lungs, even within asthma, mucus is changed, the airway caliber's changed, the inflammatory cells are changed, there's treatment going on in there. The only way that you can start to find out where these compounds are coming from are probably doing controlled experiments like bronchial challenge studies or pre and post treatment studies and things like that, where you've got paired data from the same patient, so you can compare changes before and after making some sort of change. And then at least you can hypothesize that the breath samples, the breath volatiles have come from as a result of that change rather than anything else. Probably, one of the best ways to do that is by doing some sort of paired challenge study, really, or a treatment study.
Yeah, that makes sense. One of the questions I had, so you mentioned earlier, both in terms of diagnosis and looking at treatment, it seems one of the big challenges is actually the accuracy of the label that you apply. Do you think that seems to be more problematic in things like asthma, for instance, compared to maybe other diseases such as lung cancer, where the accuracy of the label is quite clear. It sounded like you had to do urine-based analysis to deal with issues around compliance for some of the therapeutics, and as I say, you measure obstruction or other factors. Do you think that is one of the biggest problems in?
Yeah, the gold standard in asthma obviously is kind of woolly at the moment. Even going as far as we're going within this Radica study, where we're doing every single diagnostic test that any guideline worldwide would accept as a diagnostic for asthma. We're doing that, but even within that, actually, the gold standard is a clinical diagnosis of 3 of us consultants making a decision. And so it's not hard and fast. It's not like cancer. It's not like you've got some cells that you can see are abnormal, and you can even look at the genetic profile of those cells. It's not the same, but it's a massive area, asthma, and I still think it's worth us going down those routes. The other thing again is to just start to look at subtypes of asthma, and maybe just look at responses to treatment or some very specific niche that you really can define very carefully.
Do you think VOCs have the role to essentially be a more objective measure? So once we design the right types of studies and get the right level of evidence, would VOCs actually help to steer?
I think because of the potential for the different sources of VOCs in asthma, for example, then I envisage the most likely application will be in things like predicting treatment response to certain treatments that impact specific parts of the immune system. Phenotyping and stratified medicine, I think, is where it's at, rather than blunderbuss diagnosis.
Excellent. Well, I think that's all the time that we have, Steve. So thanks so much for that. Really appreciate your insight as always.